All right, so thank you so much for coming to the VMAP Emergency Department webinar series. We did 3 of these last year. We are doing several more. Today, we're going to be talking about substance use in adolescents and young adults in the emergency department. So that is the focus of our talk today. We do have Dr. Anna Peretti and Dr. Sequeira, who will be leading this conversation. There will be time for question and answer afterwards. And I wanted to let Dr. Watts have a few words. She is our physician lead for this project and has been working with it since the beginning. So Dr. Watts, if you just want to welcome people, and once that is done, we can dive right in.
Absolutely. Thank you and welcome. Thank you for joining. As Kimberly said, I'm a pediatrician in Northern Virginia committed to VMAP's mission of improving youth and mental health in the state of Virginia. And I have the honor of working with the ED pilot. And our model on the webinars is to use an emergency department physician, Dr. Sequeira, in combination with one of our child and adolescent psychiatrists to highlight some of the key things that we hear from the emergency department physicians that you encounter on a day-to-day basis. So again, I'm pleased to introduce this webinar and want to thank specifically our speakers today for the work that they have put into this. So with that, I'm going to hand it back over to Dr. Anna Peretti and Dr. Sequeira. Thank you.
Right. Thank you. Good afternoon. Sorry for the delay, but finally we are here. This presentation is more of a collaboration between me, Dr. Anna Peretti. I'm a child psychiatrist working out of Lynchburg, Virginia, and Dr. Sequeira, who is an pediatric emergency physician working in the Richmond area. Today, we'll talk about substance use in adolescents and young adults. We'll mainly focus on what's the state of the situation currently. So we'll initially talk about substance use in adolescents. I'll briefly touch upon some of the common presentations to the emergency department, because given that substance use is commonly seen in the ED, but it's hard to pinpoint every substance that is being used and that is being presented at the emergency room. So we'll try and hit the major substances that can present. I'll talk about the psychiatric comorbidities, especially in adolescents. And we'll finish with some evidence-based treatments, but also disposition options for some of these individuals who present to our care in the emergency room. So this is a case that is being presented. I think Dr. Sequeira saw this case. She will present the case.
Hi, good afternoon, everybody. As Dr. Anna Peretti said, I'm Dr. Sequeira. So I wanted to present this case, and this is a case that a lot of us as emergency physicians or APPs have seen. And so Alex is a 13-year-old male with a history of anxiety. He presents to the emergency department for alcohol intoxication. He was at a party with his friends where there was marijuana as well as alcohol present. Friends reported he drank 3 to 4 mixed drinks as well as a beer. He had also been smoking marijuana. Friends found him minimally responsive after vomiting. His parents, who are at bedside, report they only knew he vaped, but were not aware about alcohol or marijuana use. When asked about recent stressors, they report that Alex has been struggling at school with his grades. EMS, right? This patient was brought in by EMS, reported glucose was 120. So very important to ensure that, the minimally responsive is not due to hypoglycemia, with a GCS of 12. And there is the, based on eye opening and verbal response and motor response. He received 4 milligrams of Zofran as well as 500 mLs of normal saline en route. So that's kind of the case that we're kind of thinking about when we go into this lecture.
Right, thank you. So when we think about where we are with the usage of substances, and this is data, it's a annual data set that is run through the SAMHSA. It's called Monitoring the Future. They survey students from 8th grade, 10th grade, and 12th graders every year, and this has been going on since 1975. When you look at the most recent data, the highest usage substances are cannabis, nicotine, and nicotine vaping, and alcohol. I don't think this is any surprise to any of us who see kids both in the outpatient and in the emergency room. What is interesting is during the pandemic, alcohol use and cannabis use plummeted. And the presentation to the emergency room has plummeted at that time as well. However, once the pandemic is done, we have seen that the alcohol use has come back to pre-pandemic levels, but cannabis and nicotine continue to stay below the pre-pandemic levels. So why do we need to focus on this data? I think the most important thing is substance use does account for 2 to 3% of annual visits to the emergency room, especially for adolescents. And we have also seen that given there is a significant decreased perception of risk, especially with marijuana, we are seeing a daily increased use. Almost 78% of the 12th graders do report that marijuana is extremely easy to acquire. So there is an increase in usage as well. When we think about alcohol, and especially when we look at adolescents, the lifetime prevalence of alcohol use is about 41.5%. That's pretty high. However, when you look at the reports of being drunk, so where people have used alcohol to get extremely intoxicated, 1 in 4 of them. So these are the folks who are most likely to be presented to the emergency room. What is more sobering is that 7.5% of the unintentional overdose deaths in 2021, especially under the age of 25, are because of substances. So we just have to be focused on evaluating and treating these individuals, not just for the substance use that they may present with, but also the underlying factors that push these individuals to use substances in the first place. So when you look at the substance use lifetime prevalence by grade, what is interesting is that around the pandemic, as I said, we have seen a decrease in the usage, but we are starting to see that the usage has gone back to the usual times. However, if we take away marijuana, we have seen that the usage has decreased significantly. Because when you think of the 80s, the usage of substances was pretty high, around 40, 50%. But now we are looking at low teens, so which is good. But if you look at alcohol, when you look at alcohol, the challenge is that it is decreasing, but it is not decreasing enough. And when you look at being drunk, and that continues to be high, we are looking at around, especially with 12th graders or even younger kids, when you look at 12th graders, you see it around 40%, but with even younger kids, we are still looking around 7 or 8%. Given the prevalence of vaping, daily use of smokeless tobacco, which is like ingestion of tobacco that used to be pretty common, has decreased significantly. However, when you look at vaping has continued to increase. Even when you look at 8th graders, it started off around 5% and it's peaked around 15%, and it has decreased during the pandemic. Same is the case with 12th graders and 10th graders. So vaping continues to be a major public health issue. The same trend is also seen with vaping, especially also with marijuana. When you look at marijuana use, 30-day prevalence of marijuana use by gender, what is interesting or sobering is that the usage in females is almost equivalent to males. So there does not seem to be a significant gender difference at this time. Alcohol usage is also very similar, but we see that during the pandemic it has decreased, but it's increasing again. So when we look at the overdose deaths, this is pretty high, right? So when you look at 2018, we are looking at about 253 adolescent deaths. But when you look at usage of opiates per overdose, nearly 4 out of 5 adolescents who died by an overdose is caused by an opiate. So the question is, why are these folks using substances in the first place, right? There must be a reason why folks use substances. So the commonest answer typically is escapism, because most of these individuals do struggle with a lot of challenges, including family issues, low self-esteem, and other mental health issues like depression or other mood disorders. Sometimes it's also peer pressure and recreation, especially in adolescents. That seems to be one of the biggest risk factors. If there is a family history of addiction, these individuals are at high risk. Availability, especially in terms of marijuana. Marijuana is ubiquitous these days. Because of that, we are seeing a lot more adolescents using it. Family history and genetics play a huge role. So let's say we have an individual who presents with a suspected substance use. How do we evaluate, right? So when we think of a flowchart of evaluation, as with any suspected intoxication, we always look at airway, breathing, and circulation. If the airway, breathing, and circulation is intact, we'll check for mental status. If the mental status is intact, we'll try and focus on a toxidrome-focused history and physical examination that is focused on the toxidrome that is presenting, and then lab studies, right? And then we manage based on the symptoms and presentation. Let's say if the individual has ABC intact, but has an altered mental status. When they have altered mental status, we need to look at whether the individual is presenting with agitation symptoms or depressed symptoms. If there are agitated symptoms, the commonest conditions or the substances that we need to look for are stimulants, alcohol, and anticholinergics. If it is a depressed state of altered mental status, we need to look for alcohol, opiates, and marijuana. If the individual is agitated, the best treatment is using benzodiazepines to sedate them. And if the sedation is successful, then we evaluate. But if the sedation is not successful, we may need to think about intubation of these individuals to manage them. If the individual has a depressed toxidrome, we need to look at protecting their airway and then resuscitation. If we suspect opiates, naloxone is needed. Yep. And then with naloxone, depending on the severity of presentation, supportive ventilation may be needed. So when I talk about toxidromes, some of the commonest poisoning syndromes are, so we can group them into either excitatory syndromes or depressed inhibitory syndromes. So in excitatory syndromes, there are 4 common typical categories. The commonest one is the sympathomimetic toxidrome. These individuals present with hypervigilance or an agitated delirium, and also can present with hallucinations and paranoia. If we look at their vital signs, most of their vital signs are increased, and their skin may be wet. Pupils are typically dilated in excitatory toxidromes. Other manifestations can include seizures or widened blood pressure or pulse pressure. If we are seeing this kind of presentation, the commonest causative agents that we need to think about are amphetamines and cocaine, especially if we are suspecting substance use. But also there are some of the medications that can be used in an overdose that can present with this presentation. Then if we think of anticholinergic presentations, individuals typically present with agitated delirium and hypervigilance, but they also can present with hallucinations, typically visual. A lot of the time, toxidromes rarely present with auditory hallucinations. They tend to typically mostly present with visual hallucinations or tactile hallucinations. Some individuals do present with speech deficits or difficulties. Vital signs are increased. However, in an anticholinergic toxidrome, the skin condition is dry and flushed. Pupils will be dilated, and because of the anticholinergic activity, mucous membranes will be dry with decreased bowel sounds and with urinary retention. When we are thinking of this, we need to look at antihistamines and atropine and other similar agents. Especially from a psychiatric point of view, tricyclic antidepressants or phenothiazines can cause it. Thankfully, tricyclics are rarely prescribed these days for treatment of depressions, but if there is availability, we need to think about it. Then if we think of hallucinogenic toxidrome, so these are individuals who do present with significant hallucinatory phenomena, depersonalization phenomena. Sometimes they present with synesthesia where they are mixing up two hallucinatory phenomena. So the common things that we think about are some individuals talk about tasting their music or touching their colors. So they have two sensory phenomena that are intermingled and they talk about those things. When we see these kind of presentations, we need to typically think about ketamine and MDMA. So the MDMA, the common street name is ecstasy. So these are the things that typically present with hallucinogenic toxidromes, and also LSD and psilocybin, the magic mushrooms. Serotonin syndrome can also present with an excitatory phenomena with agitatory delirium, confusion, typically more common with tricyclic antidepressants and monoamine oxidase inhibitors, but can be seen with SSRIs and SNRIs. So we just need to be careful. If we think of inhibitory toxidromes, opiates are the most common ones. In opiate intoxication, we tend to see more of sedation, or if it is severe, coma, with the decreased vital signs and constricted pupils to the point of pupils being pinpoint. If we are thinking of a significant opiate usage, we may need to look for needle marks. And the commonest ones are fentanyl these days, heroin, morphine, methadone, oxycodone. The other toxidrome, especially with inhibitory toxidrome, is the sedative hypnotic with benzodiazepines, where people will present with sedation, confusion, or coma. And then there is the cholinergic presentation. Typically, it's not commonly seen in the US, but however, if you have worked in developing countries, especially in Asia, where pesticides are commonly used and available to individuals, we do see a cholinergic toxidrome where individuals present with sedation, confusion, and seizures. You will see hypersalivation, significant incontinence, and it's typically due to organophosphate poisoning. All right. So let's say we have individuals who come to us in the emergency room and we suspect them of using substances. So what do? We have evaluated and managed them with their airway breathing. So how do we figure out what they are using? So the commonest tool that we use is a urine drug screen. Urine drug screen or immunoassays. The common basic urine drug screen tests for 5 substances: amphetamines, cocaine, marijuana, opioids, and phencycline. These are the common ones. And the cutoffs for these things are federally mandated, so it's uniform throughout the country. And the positive cutoff levels were set to minimize false positives. So if individuals do become positive on the drug screen, it's more likely that they have used it. However, the urine drug screen are challenging in the sense that they do not pick up a lot of the common things that people are using these days. Ketamine typically is not picked up unless you're specifically looking for it and you order a drug screen that is specifically tailored to that. LSDs are not picked up. Synthetic cannabinoids like K2 are not picked up at all. And even opiates, synthetic opiates like methadone or buprenorphine are not picked up unless you ask for them. However, we also run the risk of false positives because of cross-reacting substances. So if we are thinking about someone presenting positive for amphetamines, but we are not sure by history that they are using anything. So these are some of the medications that can show up as positive. Nasal decongestants, if they are used in high enough doses, can show positive for amphetamines. Bupropion or Wellbutrin, which is an antidepressant, can present as positives as the same as Prozac or fluoxetine. With opioids, poppy seed ingestion can present as positive, but it's very, very rare. You have to be eating significant amount of it for it to be positive. But diphenhydramine, when used in higher doses, or even fluoroquinolones can present. I have seen a few kids come positive for opiates on Seroquel, but that's not common. Phencyclidine can be positive with these medicines, especially ketamine, venlafaxine. I have seen one case where they came positive as using phencyclidine, but they were actually on venlafaxine. Marijuana will be positive with any of the hemp-containing food products. Sometimes NSAIDs can present positive as marijuana as PPIs. Cocaine, it's very rare to come positive unless they are using coca leaves, but these are individuals who are used to using them, and they are more indigenous plants for certain cultures. So I'll talk briefly about marijuana, because this is one of the most common presentations that we see in the emergency rooms, especially with adolescents. Marijuana, the challenge is that marijuana currently, the products have significantly increased levels of THC. If we look at the levels of THC, in 1995, it's about 3%, but currently it's about 14% and increasing day by day. In marijuana, tetrahydrocannabinol is the most psychoactive ingredient. Typically, adolescents use it to say they chill out or feel less anxious. However, for individuals who either do not tolerate it or who have taken significant amounts, they typically present with anxiety or paranoia. When individuals present to the emergency room with those presentations, they can also have physical effects that can include tachycardia, hypertension, conjunctival injection, and nystagmus. Some individuals rarely present with slurred speech, ataxia, drowsiness. Agitation and lethargy are less common, but seizures can happen, but they are rare. Psychosis does present, but these are individuals who are more vulnerable or genetically inclined to present with psychosis at some age. The challenge with individuals who are using substances, especially adolescents, is that the first presentation of psychosis or first episode of psychosis does also have a peak at between 14 and 19 years of age. Most of the individuals who present with psychosis do present at that age. So that's where the challenge is. Common forms of ingestion include smoking, edibles, e-cigarettes, and dabbing. Dabbing is concentrated resin. It's called hashish, and people use it to vaporize it because it gives you a significant high level of marijuana, because the delivery system is faster as well. Synthetic cannabinoids or K2 and spice, they are more potent. Even though they are not structurally similar to THC, they seem to bind to the cannabinoid receptors at much more significantly higher strength when compared to THC. Because of their increased potency, they present with significant neurological effects, including agitation, seizures, and psychosis. Some individuals do present with arrhythmias, rhabdomyolysis, and renal and hepatic failure. Thankfully, these are not common, but need to be aware of. These do not show up on drug screens. I'm not aware of any specific drug screens that these things show up. I know that people are working on it, but this individuals who promote these things tend to make these molecules much more different. So we're always on a catch-up game with this, unfortunately. So how do we manage marijuana intoxication? Let's say someone presents with marijuana intoxication. The key is evaluating ABC and doing supportive care. If individuals do present with significant agitation that is refractory to supportive measures, benzodiazepines are recommended to calm them down. We can start with either lorazepam or diazepam at a low dose and manage the anxiety and agitation. If individuals are using marijuana at significant amounts, they can and do present with cannabis hyperemesis syndrome. It's defined as cyclical vomiting for at least 3 months after 6 months use of excessive usage of marijuana. It is a clinical diagnosis. Individual present with intractable vomiting, and this is cyclical in nature. What is interesting is that typically the symptoms of hyperemesis do decrease after hot showers or baths. The treatment is symptomatic. However, if the symptomatic treatment does not help, benzodiazepines and haloperidol have been reported to be effective in managing the emesis. If you are thinking of using benzos, lorazepam at 1 milligram IV every 6 to 8 hours for sustained emesis can be used. If you want to use haloperidol, the dosage is up to 2 milligrams IV with a maintenance dosing of 2.5 to 5 milligrams IV. Alcohol. So this is one of the commonest reasons for adolescents presenting to the ED, either with intoxication or withdrawal. If adolescents have never drunk alcohol before, they can show signs of effect at serum ethanol levels of 50 to 100 milligrams per deciliter. And severe toxicity is typical at levels greater than 200 milligrams. They too typically present with diminished fine motor coordination, agitation, impaired judgment, or gait and loss of coordination. In extreme cases, they do present with lethargy and coma. Hypoglycemia seems to be pretty common in adolescents, so that's the reason why we need to focus on managing their taking their blood glucose levels and managing it. Poor management of hypoglycemia can lead to agitation and seizures. So when we are managing alcohol intoxication, securing ABC and supportive treatment is paramount. If the individual is agitated, use benzos and antipsychotics, but be cautious with benzodiazepines because their respiratory systems are already depressed because of the alcohol, and we don't want to make it worse. If the individual is present with hypoglycemia, that need to be managed. Monitoring serum alcohol levels can help direct treatment. One of the things that we need to think about is tools that can be used to assess withdrawal, as alcohol withdrawal is also pretty common. The incidence is about 2 to 6.7% in adolescent and adults up until age 25. Mild withdrawal typically presents 6 to 24 hours after the last drink. They do present with restlessness, tremor, hypertension, and tachycardia. It usually resolves within 24 to 48 hours. Severe withdrawal does present with 12 to 24 hours after the last drink. And when individuals are in severe withdrawal, they present with hallucinations, withdrawal seizures, and delirium. And hallucinations typically present as visual hallucinations or tactile. Auditory hallucinations are not that frequent. Typically, alcohol withdrawal severity is measured by SIBA. It measures and rates about 10 criteria with a score ranging between 0 and 67. The criteria it evaluates are nausea, presence of nausea or vomiting, tremor, anxiety, agitation, sweating, orientation, tactile disturbances, visual disturbances, auditory disturbances, and headache. This tool can also be used to monitor response to treatment. I'm not going to open the link, but this is the link that you guys can use to look at it and use it. So when you look at the scale and the scoring, if the score is between 0 and 9, there is an absent withdrawal or no withdrawal or minimal withdrawal. If the individual scores between 10 and 19, mild to moderate withdrawal, and more than 20, it's considered severe withdrawal. So things to think about when managing the individuals who present with significant alcohol withdrawal. Treatment is lorazepam and diazepam. Those are the two medications that are first choices. Mild withdrawal, it is recommended to use 2 milligrams of lorazepam IV and then just monitor. Moderate to severe withdrawal, lorazepam can be used in doses of 2 to 4 milligrams IV, but repeated every 15 to 20 minutes until symptoms are controlled. Diazepam can be used as well, but we use it at 5 to 10 milligrams doses. If, however, symptoms are refractory to initial treatment and individuals are presenting with seizures or significant agitation, intubation may be necessary. So how do we dose the medication? So these are some of the guidelines. So we can use different strategies for treatment. If the total CUS score is 8 or higher, we can use a symptom triggered method where we use medication as needed to manage it. If the CUS score is 15 or higher, individual may need to be on scheduled medication with lorazepam or diazepam to manage the withdrawal, and then use PRN medication on top to control agitation. If individuals are having any of these symptoms, we may need to think about intubating and transferring to ICU. If the total score is about 35 and we need to assess them every hour for more than 8 hours is required, or if we are needing more than 4 milligrams per hour of lorazepam for 3 hours, or 20 milligrams per hour of diazepam for 3 hours, or if the individual has significant respiratory distress. These are the conditions in which it is recommended the individuals be managed in an ICU setting. Stimulant medications, these can include prescribed amphetamines, but can also be caffeine, MDMA, methamphetamine, and cocaine. They typically present with tachycardia, hypertension, diaphoresis, tremor, and mydriasis. Behaviorally, they are more agitated, hyperactive, and some individuals do present with repetitive stereotype behaviors. These can be physical behaviors, but also can be verbal. If we see bruxism or continuous grinding of the teeth, we need to suspect MDMA. That's very specific for MDMA. If we see individuals with psychosis, but also present with rotten teeth, these are individuals who may be using methamphetamine chronically. So how do we manage individuals who had a stimulant overdose? Benzodiazepines are the first lines after stabilizing them. If individuals do present with hypertension, but it is recommended to avoid beta blockade, as beta blockade tends to worsen the hypertension. It is recommended to use benzodiazepines aggressively, as benzodiazepines can manage the hypertension as well. If the individuals are significantly agitated, benzodiazepines are recommended to be the first line of treatment, but haloperidol can also be used. So as methamphetamine, intoxication, they do present with hypertension, tachycardia, agitation, and psychosis. What is interesting about methamphetamine presentation is that individuals present with hyperthermia. However, the hyperthermia is not effectively treated with NSAIDs. It is recommended for individual come in with intoxication of methamphetamines using internal and external cooling methods to decrease the body temperature, while monitoring the risk for rhabdomyolysis, as these individuals do present with significant risk of it. MDMA, the common names are Molly or ecstasy. They're typically associated with raves or music festivals. They do present with amphetamine toxicity, but also the present with hyponatremia, seizures, and serotonin syndrome. If we do see serotonin toxicity, benzodiazepines are the recommended treatment. Right. So cocaine, most of these individuals who use cocaine do present with chest pain and cardiovascular symptoms. So these individuals need to get a chest X-ray and troponin levels. It is recommended that benzos are the first line to treat and stabilize them. And once they are stabilized, oral aspirin 325 milligrams, if there are no contraindications, is recommended. However, if the symptoms continue to persist, nitroglycerin should be used. American Heart Association does recommend against using beta blockers in cocaine-associated acute coronary symptoms, as it seems to make things worse. With cocaine users, the intoxication, the challenge is there is a significantly increased direct risk of ischemia and thrombus formation. All right, opioids. This is the most commonest cause of death from drug overdose, especially substance overdose. Opioid overdoses cause CNS depression, respiratory depression, and meiosis. Respiratory depression is the most concerning, so we need to focus on respiratory management in these individuals. If we suspect opioid overdose, naloxone is the preferred treatment. Start with 0.4 milligram per dose, IV or IM, until response. Intranasal naloxone can be used at doses of 2, 4, and 8 milligrams, but they are not as effective as IV or IM. So with naloxone, depending on the route of usage, where the onset can be pretty quick, within 2 minutes for IV, 2 to 5 minutes for IM, but it takes for 5 to 8 minutes for intranasal. Duration of action is about 30 minutes to 2 hours. And we need to think about repetitive dosing if we are suspecting people, especially with methadone overdose, because methadone is a significantly long-acting form of opiates. Opiate withdrawal typically is not life-threatening outside of the neonatal period. So there are 3 stages of presentation. Typically, the stage 1 that presents with first 8 hours after the last usage. So individuals present with significant anxiety and craving for the usage of the drug. Stage 2 is between 8 to 24 hours of after the last usage. Insomnia is common, restlessness, significant lacrimation, and rhinorrhea with diaphoresis. Stage 3 lasts up to 72 hours after cessation of usage. These individuals typically present with GI symptoms, tremors, and muscle spasms. Opiates can be used to manage the withdrawal. However, if an adolescent is motivated to quit, it may be beneficial to start buprenorphine, which is a partial agonist, started sublingually at 48 milligrams to start the process of helping the individual to quit. Buprenorphine, given that it is a partial agonist, need to be started once the individual is in withdrawal, as if the individual is still intoxicated, buprenorphine by itself can precipitate a withdrawal. So these are the common substances that we see individuals, especially adolescents, using. But most of these individuals do have psychiatric comorbidities. Co-occurrence is more prevalent and common than we think. So when we look at the data, an individual presenting with major depressive disorder has a 26% risk of using substances versus 12% without a major depressive disorder. Marijuana is similar, 22% versus 9%. Opiates is 3 to 1%. And most of these individuals do also have a higher risk of self-harm behaviors. So these need to be kept in mind and evaluated. The recommendation is that most of the adolescents who do present with substance use challenges in the emergency room do need to be evaluated for psychiatric comorbidities. Psychosis is not typical, but can present, but he has a high comorbidity. Alcohol and cannabis seems to be the most common substances for individuals presenting with primary psychosis and also using substances. There is a bidirectional impact on disease course and outcomes. This is the reason why we recommend that individuals who are presenting with both substance use and psychosis be recommended for treatment for both rather than either or. Typically, when we think of individuals who present with psychotic symptoms and are also substance users, there are 4 common pathways of how these commingling situations happen. Individuals may have a primary diagnosis of psychosis, who subsequently use substances to treat themselves, to manage their psychosis. Or we might have individuals who have a primary diagnosis of substance use, but then go on to develop psychosis either as a manifestation of substance use, or individuals who are vulnerable with a family history of substances, of psychosis, manifesting with this psychosis because of the substance use. And then there is the co-occurrent presence of both, with the substance use exacerbating the psychosis. Or if an individual starts using substances and then they develop a psychotic disorder, and then it makes the substance use worse. For the individuals who present with the second pathway, where there is a primary substance use diagnosis and then they develop psychotic disorders, this has the best co-outcomes, especially with the psychosis paradigm. So when you think of screening, the recommendation is that individuals who present with are screened using a PHQ-9 to look for depression, self-harm behaviors, and so on. If we suspect self-harm behaviors or suicidal ideation, Columbia Suicide Scale is one of the best out there that can look at the severity of the current presentation. So what do we do with these individuals who present with both substance use and psychiatric disorders? The recommendation is to treat both, as primary substance use does increase the risk of comorbid psychiatric disorders. And the key is, especially when they are being sent home from the emergency room, to make follow-up referrals as appropriate. There are a lot of services that are available where these individuals can get support as needed. So when we think of opioid usage, cutthecrisis.com has a ton of resources, and you can search up resources that are available locally in your area, and it is pretty comprehensive. If we are thinking of local resources for individuals, community service boards are a good place to start with. Most of them have substance use treatment teams that can take referrals and help manage these individuals. These individuals does not need to be using substances at a severe level to be referred. Individuals who are experimenting with marijuana, nicotine, these individuals can be referred as well. And it is currently recommended that if you suspect substances use, the referral may be the best option to get these individuals in treatment, even though they may not be ready to change their ways. Even though when we think of the cycle of change, even though when they are not ready, the motivational support can be helpful in decreasing the usage and also improving the outcomes. Findtreatment.gov is a website run by SAMHSA, and this is mainly for finding treatment facilities, especially for opiate usage, long-term detox places, opiate users and long-term detox places, and also opiates and alcohol. For psychosis, if we are seeing an individual in the emergency room who has a first episode of psychosis, there are first episode psychosis teams at the local community service boards Unfortunately, in Virginia, not all service boards are the same. So not all community service boards do have these teams, but a lot of them, especially in densely populated areas, do seem to have a team. It is recommended that these individuals be referred to these teams. So they take individuals age 14 and above, and they tend to follow them up until the age of 21, and they get them connected to supportive services and treatment facilities within the community, and they continue to follow up. Legal options are also present. Chin's petition, especially if parents are presenting to the emergency room along with the individual and saying that they are doing everything they can, but the kid is not helping themselves, or their parents continue to struggle with how to manage them. The Chin's petition is done at the local uh, courts. They can talk to the county clerks at the courts, and they can help the parents file the Chin's petition. So there is a legal aspect of helping these individuals try and manage their substance use. I think that's it. Right.
All right, thank you so much. That was great. Are there any questions that anyone has? You should be able to take yourself off of mute and ask your question. If you cannot do that, if you have a question, feel free to drop it in the chat. We can also answer them that way. Also wanted to let you know that in the chat as well, Jordan has put the survey that we would like for you to complete. That will get you your CME, as well as give us some information about the effectiveness of the training and things you might like to see in the future. So if you can access that, it is in the chat, and it's a SurveyMonkey survey, so pretty self-explanatory. Dr. Sequeira, did you have anything that you wanted to add, or anything that you wanted to say after the presentation?
Yeah. Thanks for asking, Kim. So basically, the big thing, from an emergency medicine physician standpoint is recognizing that, substance abuse and not substance use is very common in adolescents. And so it's something that we really do need to be asking about, even in like when a patient presents for whatever presentation, whether it is anxiety, depression, even something as simple as, I just needs resources, right? But it's really important to be asking these questions to prevent that patient from ever coming in for an intoxication, right? Dr. Anna Peretti did a great job in explaining, management of, alcohol intoxication, marijuana, cocaine, opioid, goals there is also to intervene, right? So it's not just about, okay, manage that opioid intoxication. It's okay, let's start talking about quitting. We are, sometimes that front line, that the only ones that might be able to do something about it then and there. Otherwise they might get lost to follow up, right? So it's just very important that we all kind of we recognize the issues and we address them head on, and get those resources to the patient.
How prevalent, we've been hearing about opioids and the opioid crisis, for a while now. And I know you're in the emergency department daily. That's what you do. So how frequent or how prevalent is that still in Virginia? You're in the Tri-Cities areas, and I know it varies, but for your part of the state.
Yeah. So, I mean, I work mainly in Petersburg as well as at Colonial Heights. We see a varied pediatric population. So I see adults and kids. Honestly, when it comes to opioid intoxications, I don't see that as much, but there are kids, there are adolescents that get their hands on opioids, right? So very rarely do I actually see that, at least in my location of opioid intoxications. But I've seen a good amount of marijuana intoxication. Hyperemesis cannabinoid syndrome is huge. We see a lot of that.
Oh, wow.
Mhm. And then also young kids who also get their hands on gummies and whatnot, right? So we see kind of a variety, but not so much in terms of adolescents with opioid intoxication. Though, if you bring it up, yes, they have gotten their hands on that, or you hear the stories of getting their hands on Ritalin and Adderall for schools and such, so to help them study and such. So unfortunately, that does still exist, but not so much in terms of intoxication in that regard.
And I think, different parts of the state, again, we don't have that many pill mills, on this side of the state anymore. But out in Southwest and other places, they can still get those fairly, I won't say easily, but, they are much more available. Marijuana is much more available in this part of the state. I'm talking central and south. So that's very interesting. I was not aware of the emesis being an issue. That's a hard word to say. So that sounds miserable. It should be enough in and of itself to make someone want to quit. But thank
I
you for
think
your
with the marijuana, the potency increasing and availability increasing, I think we
Mhm,
are going to see more than what we are
mhm,
seeing, unfortunately.
mhm, mhm.
Yeah, I
Is
think
the
that is.
potency increasing? Is that a uh, man-made intervention, or are they growing it? Like is it like pesticides on vegetables where
Yeah,
man?
it's more genetic engineering because the more potent the strains are, the more selectively bred they are. So we are seeing just the marijuana leaves being way more potent than when compared to 20, 30 years ago, even 5 years ago.
And
And it's
kids are
going to
not
get
going to even
worse.
think about that when
Yeah.
they're trying to get high. They're not going to think that this is not the same marijuana that my parents smoked.
Right, or
Yeah.
even like a month ago, right? Like you could even you never know what type of marijuana, you're getting. Just kind of same thing with like opioids, right? Like what you think you were taking, that the dosage you thought you were taking was not
Yeah.
actually the correct dosage that you've taken before, right? And we've seen that. We've seen a good number of people who, yeah, I've always taken X amount of marijuana, or and this time around, I don't know what happened. I don't know if it was mixed with something or a higher potency.
It, do you find it coming in where it has been mixed, or laced with something else and they just are unaware? I mean, because I would think most people would get it from a reputable source, but if they're just getting it on the street, do you have it coming in where it has been contaminated or dealt with anyway?
So it's tough to know because, urine drug screens are very limited. They have a very, high, they don't catch everything, first of all. And a lot of it is just based on the story that we're getting, the physical exam findings, symptom signs, right? So it's hard to know whether it was laced with something else. A lot of urine drug screens don't technically, most of them don't actually catch fentanyl. Some places do have, fentanyl screening, but so it's really tough to know.
Yeah. Well, this has been great. Thank you so much. If there aren't any more questions, I guess we will give everyone a few minutes in their day back. Again, thank you for your patience. Earlier on, we were trying to get all the technical difficulties worked out. This will be available for review and to share with others. Once that happens, we will reach out to you via email with the link where you can access this if you want to share it with colleagues. If they access it via the VCU CME portal, they will also be able to get CME credit for it. If they access it directly through the VMAP website, they will not get credit. So either way, you choose to watch it, please spread the word. This was a great presentation, and we would love for it to be sent to additional people. We will also continue this series in the first quarter of 2025 with our talk about the TBO and ECO, temporary detainment and emergency custody order. We will be partnering with the Department of Behavioral Health Services for that webinar, and stay tuned for more information on that. Thank you all so much for coming today.